All right, there we go. So each of us have homework to do in choosing our plan, our Medicare plan for 2024. They're always changing. I don't know about you, but I got a notice in the mail this week that said your monthly fee is going from $33 to $60. So for two people, you know, that means $720, basically more expense. So we need to look at each plan and what our needs are and how those plans will meet our needs. So today we're fortunate to have with us the Insurance Commissioner, Mike Kreidler, who has been in office 23 years and has one more year and will retire in 2024. And Tim Smolian, who is the head of SHEBA, Statewide Health Insurance Benefit Advisors. And so they'll provide information to help us do our homework. Okay, Commissioner?
Thank you very much, Jim. And it's indeed a pleasure to have an opportunity to be here at Horizon House once more and talk to you about Medicare and the open enrollment as it's coming up. Can you hear me all right? Good. Louder? Really? Really? This is what you call eat the mic, you know? Right, okay. This is one of the most pleasurable things that I have, because maybe it's because we actually have a healthcare program for seniors and for people who are disabled and qualify, but principally seniors, to have this program. But it is, as Jim was pointing out, it's constantly going through modifications and changes over time. And I think that's the challenge that you as individuals have, is to know whether what I have right now is that the best for me personally. Is it my doctor and hospital going to be a part of any, if I do make a change, it might be a little better for me financially, but it might be worse for me because of relationships that I've established. These are the kind of questions you'll have a chance to explore and see, to make sure that if you do make any changes, or if it's your first time, as it will be for me as I come up after I retire. How's that? I'll be 81 when I sign up for Medicare. So I wish I was still Medicare age at 65, but I won't get. They won't give me a choice of a trade on that one. But it is something that all of us will wind up then having as something to really follow and track and make sure we do the best. I can tell you one thing: when it comes to the Medicare plans, we work hard from the standpoint of the Office of the Insurance Commissioner to get the information out about it. Part of the challenge we have, and I don't know if Tim's going to touch on this, but we clearly have challenges around the issues of Medicare Advantage. We don't regulate the marketing of Medicare Advantage. We do Medicare supplements, but we don't Medicare Advantage. There was speculation that Medicare Advantage was endorsed, supported by George W. Bush as a way of trying to kind of wean people off of Medicare. And this was the way of trying to push it back into the marketplace, and clearly having oversight of Medicare Advantage at the state level, as it would be in our case, where we, as the Office of the Insurance Commissioner, do for Medicare supplements, but not for Medicare Advantage. If you did it for Medicare Advantage, then you'd be weakening the argument. That's the story as it's told right now. For that reason, one of the legacies is we don't have oversight on the Medicare Advantage. We certainly follow it very closely. We provide advice to people as to what their choices might be, but at the same time, we don't have the hard regulation that we have with the Medicare supplement program, which are your two major choices for Part B. And now, that's one that we're hoping will change. There is a move afoot, and there's even legislation that's being proposed to give the states the authority to have regulatory authority over Medicare Advantage. I'll tell you, I'm one of those guys that loves to do treadmill in the morning, and I should stay away from any of MSNBC and CNN and some of those because of the constant advertising for Medicare Advantage and the misrepresentations that they put out there. And so it's a good thing I'm out in the barn because my wife would say, "Would you stop screaming?" Because it irritates me so much when you hear things that are clearly misrepresentations of the facts that can be very confusing for individuals. So if you have questions, believe me, it's coming at you not always just because of because we're all getting older. It's happening because they're giving us bad information. And I certainly see it, and it drives me crazy when I do. I have no regulatory authority over that advertising, and I'm not trying to get Joe Namath to retire along with me, but at the same time, I'd really like it if they wound up being much more accurate, and that's something that if we do get that regulatory control, and like I say, legislation's been proposed, and the insurance commissioners in the country have uniformly submitted a request to the Health and Human Services to urge them to support turning that responsibility back to us so that we have that control. As it stands now, when we run into a hard problem, we send it to Region 10 here in Seattle for them to work through it. They don't have the personnel or the same kind of involvement that we do at the state level. And that's why we would like to have that regulatory control so that we can make sure what is said and what is done is not only compliant with the law, but it's fair and honest to consumers. So when you have a complaint, have an issue, we can do something about it. But the person who can help us now with help you answering these questions is my director for the State Health Benefit Healthcare Advisory Program, SHIBA program, and that is Tim Smolin. So I'm going to ask Tim to come up because he's got much more of the answers than I do. So Tim, come on up here and save me from saying something I shouldn't. So.
Thank you. Oh, goodness. I'm so happy to be back here. Risa, okay if I just use the hand mic? Yes, Risa says yes. Risa's the boss of me here. Risa and I worked together last year. Could I have show of hands? How many of you were here last year when the commissioner and I were here? That's not bad. That's not a bad endorsement. I recognize many of you. You all look better this year than last year, so you're aging well. Congratulations on that. I just had a revelation. I lost her card. I walked down to use the restroom and I'm drinking your coffee for free, which I don't think is an ethical violation, but I'll find out when I get back to the office. But you have a director of inner well-being and spirituality. How many of you knew that you had a director of inner well-being and spirituality? About the same number, no, more than were here last year. Maybe that's why you're looking better, because you've been visiting with Linda. She's an MDiv person. So with any luck, this won't make your inner well-being and spirituality worse off at the end of this program. I have, of course, a program that I put together for you, but mostly just love to have questions and answers and have some conversation. And I'm happy to stay after the program and visit with you. And Sarah, will you just wave at the crowd? My friend Sarah Volpone is here. Sarah is our newest hire in the SHIBA program. So she lives and works here in Seattle, and so she and I will stay after and have questions. Jim, thank you for your hospitality, and John and Marianne is in the back. Thank you for having us. So let's see. I think do you all know what a cone is? K-O-A-N? Does anybody know that expression? It's supposed to, you know that expression. So it's supposed to like help you focus your mind, right? It's like a question that helps you focus your mind. So the famous one is like, what's the sound of one hand clapping? Or if a tree falls in the forest and no one's around, does it make a sound, right? I don't have one of those today, but I have a riddle for you just to help, kind of get you in the mood for today's program. So the riddle is, what does a dog do that a man steps into? I give you a moment. Take your time. It's a riddle, friends. It's a riddle. It's not vulgar. If you're thinking something vulgar, that's a different program down the hall. This is PG all the way. What does a dog do that a man steps into? Yeah, well, we said no vulgarity, but thank you for that. The answer is pants. See? You're thinking, that guy works for the government, but he's pretty sharp. No, I actually have no idea what you're thinking. But you're gonna find out what I'm thinking here in a second. You get it? All right. It's all right. It's not easy. Okay, so I first want to just appreciate my boss, the Insurance Commissioner Mike Kreidler. Commissioner Kreidler and I have known each other since he came into office 23 years ago, and I am a big fan of his and a strong supporter of his leadership, and very grateful that he hired me to work in the SHIBA program. And so you can go to our website and read a brief biography of his illustrious career and some of the significant things he's accomplished in our agency. This is my contact information, which Risa is going to make available a copy of the slide deck and record the program, right? So you can reach me directly at that number or email. So I'm looking forward to hearing from you. As I said, I'll try to be brief enough in my remarks that we can have some time for questions and answers, because I think that's the most enlightening. But probably the most productive thing is that you're going to call after the program and talk to one of our volunteer advisors. Do you need a pen, George? I have an extra pen. George and I got to meet a little bit ahead of the program. I like to meet as many of you as I can just to get a sense about what you care about and what brought you out today, so I can have a program that is meaningful for you. So here's the agenda for today. I'm going to talk about what Medicare is, kind of how we find it today and how it got to be that way, and a little bit about kind of crystal ball, like what we think comes next. John asked me to do a program, as the commissioner said and Jim said. Many of you might be at a place where you want to think about making a change with your insurance, so we're going to talk about some ideas about how you might go about discovering your options or evaluating your options, and I have some ideas about guidance for you in that regard, and then questions and answers. So how about another show of hands? You all have been pretty game so far for chair yoga. So could we have anybody who has heard of the SHIBA program before? Sarah, please raise your hand. Thank you. The commissioner didn't raise his hand. I don't know what to think about that, but I'm not going to take it personally. We work just down the hall from each other. And then how about anybody who has worked with a SHIBA volunteer before? You've had a chance to have a conversation or a consultation, just a small number of you. Okay. We got to get more of you to have more contact. Today's program is a lot about kind of practical reality, but it's also about emotional reality. The older I get, the more I'm in touch with my feelings, so I have a good head start on talking to Linda, the Director of Well-Being. So first, on the material side, there's real consequences for not understanding your rights and protections, or kind of the rules and being on time. There are, unfortunately, people, as the commissioner suggested, that would take advantage of you or exploit you, so not knowing to whom to turn, right, can be a little perilous. And I think that, we're becoming more aware, and, obviously John, our, who invited us in the Wellness Committee, that feeling, that confusion and frustration and that kind of bitterness, that takes a toll on a person. So there's an emotional kind of undercurrent about dealing with this stuff that I think we should not underestimate. So part one, about Medicare, where are we at now? So I want to tell you about eligibility for Medicare, do a little bit of kind of myth busting here. Enrollment in Medicare, and this is where it starts to get more complicated, right? We're going to talk about coverage, which means the benefits to which you're entitled, access, which means exercising your right to that entitlement, and then additional support. And this is really about people who have limited income, which may not be you personally, but you can help us to do some outreach and help people get connected to services that they need. And then obviously other insurance besides Medicare, because 90+% of people with Medicare have some other insurance besides Medicare, which makes sense because it really works like a major medical plan, right? So you want some other insurance besides Medicare. And so we'll talk about kind of the panoply of options. That was a good Scrabble word if you're a Scrabble person, panoply. That'll get you a big score. If you can spell it, yeah, you can send me a note afterwards about spelling it, and I'll spell it for you. So if you don't already know, this is what a Medicare card looks like. They used to, this is going to sound funny when I say it, but this is really true. It used to have your Social Security number on it until 2018. And then somebody thought, gosh, this could be kind of a problem in terms of identity theft if people are just walking around with their Social Security number hanging out. So now we switch to this kind of made-up number. Number one call Medicare agency gets is, I lost my card. Can I get another one? Yes, very simple to do that. And what I mostly want to point out is what it says is when your coverage for Part A hospital and Part B medical started. Because when we talk about being eligible for Medicare, what we really mean is eligible for Medicare Part A and eligible for Medicare Part B, right? So that is really your entitlement. And so the commissioner actually is enrolled in Medicare Part A. He got that when he turned 65, so he has his own little red, white, and blue Medicare card, but he deferred enrolling in Medicare Part B because he's covered through the state system, right? And that's a very common challenge that people have. That's probably our number one question that we get in our office is, can I wait? Can I wait to sign up for Medicare Part B? It's possible, it depends, but yes. So 4 parts of Medicare coverage. Part A is hospital insurance, also inpatient services. Part B is medical insurance, also outpatient services. Part C, nowadays we call Medicare Advantage. When it came online, we used to call it Medicare Plus Choice Plans or Medicare Part C, but we've settled on calling it Medicare Advantage for now. So that's a win for the marketing people, right, at the plans. Medicare Advantage, it sounds kind of attractive and interesting. And then Medicare Part D, I'm sure you're aware because it's in the news all the time, is Medicare prescription drug coverage. So this is the beginning of our introduction to the fact that there's complexity, right? So when people say they have Medicare, well, the commissioner has Medicare, but that's different than Seth's Medicare, and that's different than Marianne's Medicare, and right, Gary has Medicare, but he's also insured through the FEHBP program, the Federal Employees Health Benefits Program. So when people say I have Medicare, that's like saying I had breakfast. I'm like, me too. Let's talk some more about it. What do you have for breakfast? What kind of Medicare do you have? How's it going for you, right? A lot depends on the details. So I'm going to send you in this presentation a link. The online version of the Medicare and You handbook is out there now. If you don't already know that, you can go online and see the 2024 version of the Medicare and You handbook. Yours will be coming in the mail soon. But I kind of cut and paste this out of the Medicare handbook last night when I was putting this together. My wife plays fiddle with some of her girlfriends on Monday night, so she doesn't care what time I get home, so I can work late without retribution. So original Medicare means Part A, Part B, hospital insurance, medical insurance, inpatient, outpatient. But for most people, they need more coverage than that, so it's common that people who choose original Medicare also elect a Medicare Part D plan and what we call a Medicare supplement plan or a Medigap plan. You'll hear us, use those terms kind of synonymously. So we'll call this like one path, right? One approach to Medicare. So if you tell me you have Medicare, I want to ask, do you have original Medicare? People will call this traditional Medicare or fee-for-service Medicare. But that's what we had until the advent of Medicare Advantage plans, as the commissioner said a couple of administrations ago, but pretty recent history, still evolving. So in this path, you're going to get your Part A and Part B benefits through a private insurance company, which I know is a concern that we're going to talk about today, privatization of the system. And most all the plans include coverage like Medicare Part D, as well as some extra benefits, which is one of the major attractions of these plans, right? So by extra benefits, we mean eyeglasses, eye exam, hearing aids, hearing exam, gym membership, right? Things like that. So Medicare, it's a government program that arouses people, right? It's a government program of insurance for elderly and disabled that helps pay for health care. And I want to kind of unbundle this a little bit because all of those features are the things that are sort of stock and trade for us in the SHIBA program. So many of you were adults already by the time we got the Medicare program. 1965, Lyndon Johnson signed the Medicare program. We got Medicaid at the same time. These were amendments to the Social Security Act, so Medicare was really modeled on how Social Security worked. And these were, really explicitly part of President Johnson's Great Society or anti-poverty programs. They were also explicitly part of his civil rights agenda. So one of the things that I most appreciate about Medicare that we don't talk about a lot is pretty well overnight we integrated all the hospitals. Because as a condition of receiving federal money, you had to be an integrated hospital. So it was we were kind of joining together a civil rights initiative and an anti-poverty program together. And so you'll see old age survivors and disability insurance system. So on your, when you were still working, I'm still working. When you were still working, you had a payroll deduction on your check that said OASDI, and that was your contribution to Medicare, right? So you've got a Social Security deduction and a Medicare deduction, and that's why when you turn 65, Part A is for free. You already paid for it, right? You earned it by paying into the Medicare system. So that's an important thing to know. Why did we have a Medicare program? Well, because the number of people who were old was growing. That's actually still true. And they were getting poorer, and that's less true. So by that measure, the Medicare program has been very successful. We went from having seniors be the most likely people to be living in poverty to being the least likely people to be living in poverty because the Medicare program sheltered people from those kinds of catastrophic health care expenses. Unfortunately, now children are the most likely to be living in poverty, so we have some more different kind of work to do there. But you can see that what we had was a large and growing older population, and they were largely poor people without insurance. So pop quiz, I know you weren't expecting a quiz, although Jim did say you had homework. So in Washington State, how many of us are older? How many of us are over age 65? Is it like it was in 1963, about 10%? Has it doubled to closer to 20%? Is it someplace in between? Who wants to vote for letter A? Who thinks it's kind of about the same as it used to be? Nothing's the same as it used to be. Friends, this is difficult, but it's true. Nothing is, it's all worse. Nothing's even better. It's not that it's different, it's worse. Okay, how about letter B? It's about doubled, like we have about 18 going on 20%. Bunch of you, less than came to my program last year. And then how about like it's going up but not quite that much. Okay, so we have a diversity of opinion, which is good. That makes conversation go better. As my old dear friend Eldridge Cleaver of the Black Panthers Party said, Too much agreement spoils a good chat. So based on the 2020 census, about 17% of us are over age 65, and in one generation, we're going to be closer to 25%. I like to think about this when I go to Winco, or Walmart, and I'm walking around and I'm thinking, pretty soon, there's going to be like 1 out of 4 people is going to be over age 65. And then in like less than a generation, it's going to be 1 out of 4 people over age 85, because they're all going to live that long, right? Because if you live to be 65, the chances of living to be 85 are almost 100%. It's just remarkable, isn't it? Get ready. I mean, if you're not already getting ready, Linda's office is right down the hall. She can help you with this adjustment to this reality. Okay, so getting Medicare is about being eligible and then getting enrolled. So who is eligible for Medicare Part A, Medicare Part B? So this is not commonly known. Most people don't know anything about Medicare, which is sad for me, but also job security. So it is for older people, but it's also for disabled people. So the 2 conditions to be eligible for Medicare are you are aged or disabled or have end-stage renal disease, so kidney failure, right, of the kind that you need dialysis or a kidney transplant. And the second condition is that you're a U.S. citizen or a legal permanent resident. Legal permanent resident in this regard means like a person who has a green card and has been here continuously for 5 years. So that's the universe of people that are eligible for Medicare. And let's just spend a second talking then about disability, because for purposes of Medicare, Social Security makes the rules about disability, and it means a person who has a disability so severe that it's expected to last a year or more or result in their death, and that it prevents them from doing gainful employment. So that decisions about who's eligible for Medicare in general for all of us are made by Social Security, but explicitly disability determinations for Medicare are by Social Security. And this is the test they have for earnings and returning to work. So there are people who are disabled, who qualify for Medicare and go back to work. It's not uncommon. So I'm just trying to represent for you that when we think about Medicare and the needs of Medicare and the complexities of changing the Medicare program, it's a lot about the diversity of who's enrolled. Oh, it's a puzzle. It's not a cone or a riddle or a quiz. It's a puzzle. Okay, how many Medicare beneficiaries are under age 65? Raise your hand if you think it's about the general number of the population in the United States, about 8%. How many think it's about 8%? A couple people. How many think it's more than 8, like 14%? Couple people. You're getting more tentative. The quizzes are getting harder. Okay, how about it's fewer than that because the definition is restrictive or other reasons it's 4%. So these data are not easy to get, but about 17%. So almost 1 in 5 people in Medicare is under age 65. And for a lot of them, their disability is mental illness. They have a psychiatric disability. So these are people that we would say have like severe persistent mental illness. So there's lots of people who have, for instance, bipolar disease, who are disabled and in Medicare. And I'm just raising the point to say that you can imagine how the needs of that person as they encounter the medical care system are very different than the needs of my mother, who's going to be 84 next month, had a fall recently. I stayed with her. She's fine. But they're going to encounter the system very differently, right? They have very different needs. They're going to make very different demands. It requires sort of a different policy prescription. So enrollment in general, the kind that most people are aware of, is that you qualify by having paid into the Social Security system and the Medicare system, and you get to be age 65, and they mail you your red, white, and blue Medicare card, and off you go. However, there are more and more people, because we raised the age to get your full benefit for Social Security from age 65 to age 67. So pity me and Sarah, we're going to have to keep working a long time, or get a reduced benefit for Social Security. So there are people who will be auto-enrolled at age 65, and then there's other people like me who is destined to work quite a lot longer. who are going to have to then affirmatively enroll ourselves, because we will not be drawing a cash benefit at age 65, because we're going to wait until we get 100% benefit at 67. And as I said, some people will wait past age 65 to enroll, and that's okay. And for some people, that's not okay. So it's wise to get some help, right? Okay, puzzle. Who knows what the standard monthly premium is for Medicare Part B this year? It's going to change in about 90 days, but who knows what they're taking out of your Social Security check now for Medicare? Anybody round numbers wise? Sarah? It's about 167, right? It's $164.90. It's going to be more next year. Spoiler alert, friends. It's going to be more next year. We don't know the number yet. We will know the number next week, but it's going to be more. And I underline standard because this is another way in which the Medicare program shows up differently for different people. There are people who pay less than that amount. There are people who the state pays for their Medicare premium for Part B, so they don't pay anything for it because they're poor. And then there's people who have a very high income that pay what we call IRMA, right, the income-related monthly adjustment amount, so they pay more than the standard premium. So, right, I'm just trying to give you a sense that Medicare is not the same for all of us, and so we should just go to that fun machine and get a cup of coffee or tea or hot chocolate and sit down and talk about it, and we'll have a more enriched conversation. I made this because it looks like a bingo chart. So what? Thanks, Barbara. So what I'm saying is that these are some of the kinds of configurations that are possible with Medicare. So there are people who have only Medicare Part A. That would be like the commissioner, for instance, right? He's going to wait to sign up for Medicare Part B. There's folks who have only Medicare Part B. That's like a bit of a riddle. We'll come back to that. People who have Part A and Part B but didn't elect Part C or D. People that have A, B, C. People who have A, B, D, A and D, B and D, or all of them. So this is one of those kinds of interesting things, right? You need to have only A or B to get prescription drug coverage. You don't have to have both. And so all of these configurations are pretty common out there in the world. Strange. Okay, so back to the idea that you probably need other insurance besides Medicare. Because Medicare really is like major medical insurance, right? Remember when Medicare came online in 1965, it was really modeled to look like the Blue Cross plans that were out in the world and the Blue Shield plans that were out in the world. And so Medicare looks like those plans. It doesn't look like our modern conception of insurance. So even when Medicare pays for a service, it typically doesn't pay 100%, and it doesn't pay for lots of things that you want, so you're going to go get some other insurance. And this chart is just an example of some of the kinds of things that absent other insurance you would pay for out of your own pocket. So you probably are getting good value having other insurance. How does that show up in the world then? I'm starting to get into the political conversation and the privatizing Medicare conversation. So if you were waiting for that, get ready. Here comes your moment. So as I said, more than 90% of people have some insurance besides Medicare. Very few people only have Medicare insurance. A significant number of people have insurance from the place they used to work, right? So Gary retired from working in the federal government. The commissioner is going to retire from working in state government. He's too modest to say, but he also has a pension from retiring as lieutenant colonel. And so lots of people have employment-related coverage. A significant number of people, their second coverage is Medicaid, right? So they qualify for extra help because they're low-income people. About 20% of people have these Medigap plans that the commissioner said that we regulate. We help set the rates for those plans, manage the marketing. Until the advent of the Medicare Advantage plans, most of the market was in those Medigap plans, and they're still very popular. And then Medicare Advantage plans are about 27% now. If John was here, John would be raising his hand and interrupting me, not because he's rude, Marianne, just because he's diligent and he's holding me to task. And he would say, but Tim, you're going to say that half of all the people in Medicare have Medicare Advantage plans. And I would say, yes, John, that's right. Because half of all the people who have coverage from their job are enrolled in Medicare Advantage plans. So if you work in state government, we're seeing people migrate away from Uniform Medical Plan into United Healthcare. If you were, like Gary's gonna consider leaving Aetna and going into a Medicare Advantage plan inside his Federal Employees Benefits Plan portfolio, right? So we're seeing more people who have insurance from their jobs. Those companies are electing to offer Medicare Advantage plans because it saves the company, or in our case, the state, so much money, right? They're less expensive. I know we want to argue about that, so I'm looking forward to it. And then about half of the people in Medicaid are also enrolled in Medicare Advantage plans. So the state is contracting directly with Humana, with Aetna, with United Healthcare to provide managed care benefits in Medicaid for poor clients, right? And so if I take half of the people who have job-related insurance and half of the people who have Medicaid insurance, and I add them to the 27% that have MA plans in the private market, then that's how we get to 50%, right? So I'm just making the point that besides those plans that, you know, the commissioner talked about, Joe Namath, Jimmy Walker advertising, there's a significant migration of people who are retirees from state and federal and private employment, as well as people who are receiving public assistance into these Medicare Advantage plans that are run by private companies. So when John says privatization of Medicare, yeah, that's real. That's really real. Okay, so we've talked about that a bit. So here's my little graphic image just to give you some context for where I'm going with the program next. So in general then, as a person in Medicare, you're going to get your benefits either through what we call the original Medicare program or traditional Medicare or fee-for-service Medicare, or you're going to enroll in a Medicare Advantage plan. So for those of you who are retired from state government, like my friend Seth here, right, you're either going to choose Uniform Medical Plan or Premera Medicare Supplement G, and in that case, you're in the original Medicare world, or you're going to pick Kaiser or United Healthcare. In that case, you're in the Medicare Advantage world. And open enrollment is the time that you can move from one side of the line to the other, or move on the same side of that little gray barrier there. Okay, so what's coming next for the Medicare program? More of the same is the answer. We're on a trend now, right? We're on kind of like a glide path. So you've heard about the Inflation Reduction Act. So we're improving access to oral health care, mental health care, preventive benefits, improving prescription drug therapy. Telehealth is going to be a continuing feature of the Medicare program. So we're seeing Medicare start to look more responsive to the needs of of older Americans. Here's a brief review about some of the significant milestones in the history of the Medicare program. As the commissioner said, 2003 is when we passed the Medicare Modernization Act and included prescription drugs for the first time, starting in 2006. And back in the Bush administration, we passed we had the advent of the Medicare Advantage plans. So my point here is that the Medicare program will continue to evolve. The pace of change is coming faster, and I think the consequences are more significant. So in general, when people are concerned about privatizing Medicare, this is the sort of phenomenon that they're concerned about. On the left-hand side, right, that corresponds to original Medicare, traditional Medicare, fee-for-service Medicare. Providers are paid under a contract with the government on a fee schedule, for instance, for doctor care. And of course, then we have this continuous argument about they're not paying enough, specialists earn too much compared to generalists, but it's all like a civil discourse, more or less, right?
The time is important.
Tell me what you mean, the time, Jim.
When a doctor files a claim with Medicare, it may be 6 months before he gets paid, or she gets paid.
Mm-hmm.
Under Medicare, they get it in a much shorter time.
That's true. Medicare is a very timely payer. Medicare Advantage, well, that's challenging, right? Let's talk about Medicare Advantage. So on the Medicare Advantage side then, what we've done is kind of inserted this private company between the providers and the Medicare agency. So now how your doctors get paid or how your pharmacy gets paid, how hospitals get paid, is not negotiated with the federal government, it's negotiated with the private insurance company. And so that, you know, for friends like John, that's the concern, is like, gosh, we're giving these private insurance companies an awful lot of influence about how much providers earn, and introducing other kinds of aspects of managed care, right? Like prior authorizations and referrals, right? Or restrictions on the network of providers, because on the original Medicare side, it's pretty well, all the doctors participate in Medicare, you see who you like, you manage your own care. And so this is a pretty significant departure, right? But this year we're going to have more than half of the people in the Medicare Advantage world, and that trend is going to just continue, right? We're going to move up 3, 4, 5% a year continuously across the next decade, right? So, you know, whether you're excited about that or fearful about that or dreadful, that is the reality about where we're going. Is that by choice? Well, that's a really good question. Would you remind me your name? I met you last year, but I can't get it back. Hi, Sam. That's a really good question. Is that by choice? I would say it's like implicit choice, right? In other words, there is, people don't want their premiums to go up. And so is it a choice to say, if you're on this side, your Medicare Part B premium can go up 10% a year, and if you're on this side, it'll go up 5% a year, and then you choose. That doesn't really feel like a choice to people. That feels a bit coercive, right? Where's option C, like my rate doesn't go up, right? Which is possible, right? Because that's a policy choice that the government could make, right? Because right now our policy choice is that as a beneficiary, you pay 25% of the cost of the Medicare Part B program, and 75% comes out of the general treasury. It would be relatively trivial just to say beneficiaries pay 20% and the treasury pays 80%, and then your premium could be flat for a long time, right? So it's a choice, right? We're trading off how much do we want to spend in the Medicare program compared to other discretionary spending or other entitlement spending, but it's absolutely a choice. It doesn't feel like a choice to you, but it's a choice that the people you vote for are making. Or maybe you voted for other people, but it's a choice that someone elected is making. And then, of course, bureaucrats like me, right? We influence all this for you. Couple of other things that are coming on the line. Lots and lots of innovations. During President Obama's administration, we created a kind of new branch of the Medicare agency called the CMS Innovation Center. So looking at ways to improve outcomes and manage the kind of bend the cost curve, right? If you go online, and I'm going to do a couple of minutes and a couple of slides here about using the tools on the Medicare website to compare your options and evaluate your options, you'll see this kind of terminology. I'm just comparing two different doctors in Medicare here, and you'll see that this thing that says alternative payment model, so the doctors have incentives to practice differently, right? And to share more information from their clinical records with the Medicare agency, right? I'm talking to you as a retired nurse. You're coming with me. Yep. Did you have a question?
Well, I had ran into some difficulty because my doctor was not a preferred, he couldn't get preferred provider.
Yeah.
And so I wanted to keep my old doctor and be covered by
Right. Tell us your name, please. Medora. Were you here last year, Medora? Were you at the program last year? I don't think I've met you before. I think I would remember you. That's a good question. So the question was about doctors trying to join networks and be a preferred provider and being told, no, like we're not taking on any more providers. And that absolutely is true. That's what happens. That's part of how these managed care plans manage care, right? How they try to they're going to choose providers that will take a contract rate they like, and they're going to choose providers that will comply with their guidelines about clinical practice and sharing medical records and other kinds of technology. So that is going to be one of those things that's going to be a challenge for us for sure. Yeah, thank you for that. Same thing with hospitals. Yep. Yep. I think last time we talked about, because John asked me to talk about accountable care organizations and this program called ACO REACH. So this is, again, another different kind of incentive program for providers. You can opt in to this program or you can opt out of this program. You would receive a letter saying, hey, your provider signed up. Would you like to share your records and treatment? And you can say yes or no, but this is another one of those things that's meant to help us aggregate data and get better at patient care and cost control. This is my pitch for take care of your data besides your Medicare card. You know, we used to be concerned about robocalls. People would call you. Now we have text, we have email, right? More intrusive ways of trying to get a hold of you, but please be careful. There are scammers out there. Our office is also the Senior Medicare Patrol Program. So, right, so identify, detect, report, prevent fraud. So if you have a concern that you think someone's doing something unscrupulous, please reach out to us. We're happy to help you. Okay, here comes the technology part of the program. I got about 5 more minutes. So tools for evaluating your options. I made this chart. Jim made his own chart. This is the back of the room. But you want something like this, you're going to need a chart, right? So you can think about how you're going to keep track of the trade-off among the costs and the benefits about the things that you care about. So I like mine, Jim likes his, you're going to make up your own, but you're going to want to come down to what are the services that I care about, how much am I going to pay if I choose this plan, what are the restrictions on which providers, prior authorizations, referrals, which suppliers can I see or which services can I get, and then other kinds of restrictions. Very difficult plan language, right? The Medicare Handbook is a terrific resource. I think they keep getting better. Every year you can download an electronic copy ahead of time. It's available now, or you can wait for one to come in the mail in case you need it for your bird cage. Are you allowed to have birds here, Risa? Can you have birds in your room? Yep. Okay. My wife would have a bird. It would make me crazy, but she would do it anyway. I'd have to go see Linda about my internal well-being. Okay, so strongly suggest you, if you haven't already, create a My Medicare account for yourself. Two really good things about this would be you can see all of your billing online, so you can turn off paper statements, and you can see all of your what we call Medicare Summary Notice, or MSN, online, which is a great tool for preventing fraud. More importantly, you can see all of your doctor visits, hospital visits, and prescription drug therapy is recorded here on the site. So if you're thinking about, I want a plan that helps with prescription drugs, you'll already know what you've been getting, what you've been paying, where you've been getting it at, the strength, the dosage, all those kinds of things, right? That can be very difficult to recollect in the moment. If you want some help navigating the site and creating an account for yourself, the nice people at the Medicare agency have made a YouTube video. I swear I'm not making this up. You can go to YouTube, and CMS, the Medicare agency, has recorded a video for you about navigating their website. So I'm sure the new version will be out there soon, but that's also a kind of a thing that one of our volunteers would be happy to help you navigate the website. Choosing a doctor, probably, as the commissioner said, number one concern. Can I keep my doctor? I have a relationship. I like this person. I trust this person. They know me. Yes, so the Medicare website, you can search for doctors, their affiliations. You can see the ratings that they get from their patients about how good they are at various different kinds of things that patients care about. So really good tool for choosing a doctor. And I'm saying doctor meaning, you know, any clinician, right? So no offense to people who are not doctors. And then, as I said, the Plan Finder tool for prescription drugs. So the more details you know about your drug, the better. So if you didn't create an account, you gotta talk to your pharmacy or gather up your records, because the more detail you include, the better the answer you're going to get about what's the best plan for you. So pharmacy preference, it turns out that people feel strongly about using certain pharmacies as well. I was on the phone with some Medicare beneficiaries in Spokane recently, and they're enrolled in Kaiser, and they were very upset that Kaiser said mail order. You can't go to Don's Pharmacy anymore. And they've been trading with Don's Pharmacy their whole life, and they want Don's Pharmacy, and they're going to quit Kaiser. And I said, okay, to each their own. So we have in-network, we have out-of-network, and then, of course, we have mail order. So you have to, and I appreciate that this is hard work, but you have to think about what are the things that you care about the most? What things are you willing to trade off of? Because there's no perfect solution, right? Sadly. So when you go through the tool, you're going to end up with something like this. That's going to show you if you choose this plan. And I'm not saying I love this one better. I love them all equally. But I just did a quick search. I live in Olympia and Thurston County. And so this is one of the many, as you can see, 46 Medicare Advantage plans in Thurston County. That's amazing, like 46, heaven's sakes. That it starts not to feel like a choice when there's 46. Then it just feels like something different that I probably can't say in mixed company. And then, of course, extra benefits, right? People care a lot about sort of things that are not part of a traditional insurance package, but are part of these Medicare Advantage plans or from the place you used to work. Lots of legal language, so pay attention to all the details. And then you can ultimately end up at comparing plans, so you get sort of an online version of the form that Jim has or that I have in the back of the room. So if you're a computer person, you can do this. If you're a paper person, you can do like me. And then we also have this thing called star ratings, and you're going to see more and more as we talk about the future of the Medicare program, getting this kind of data, which is feedback, not like Yelp feedback, but feedback from clinical records and from real people is going to become more important. And star ratings are part of how Medicare Advantage plans get reimbursed from the federal government. So a higher star rating translates to a higher level of reimbursement. So they are motivated to kind of win you over, right? Okay, last part of my program is just a pitch again for extra support for low-income people. Even if this is not you, please reach out to somebody who might need your support and guidance for paying the Medicare Part B premium or for help with prescription drug costs. There's a pretty easy online application. If you're not an online person, one of the Sheba volunteers will help you to do that. And then here's my pitch for calling us at the Sheba program. These are some of the things that we can do to help you. This is my acknowledgement that this is no joy. This is effortful, right? So I just want to acknowledge that this is, my mom says, I did not sign up for this. I should be taken care of. And I'm like, you're right. We should do a better job taking care of you. Shame on us. So on behalf of, the bureaucrats who run the Medicare program, I'm sorry. And I'm trying to make amends by, helping you navigate it through here. As the commissioner said, now's the time you can change, but you don't have to change. With some exceptions, some plans are, discontinued. They don't continue in the service area. There's other changes. But it's okay to just be on cruise control. It's okay to just stay where you're at. But I think it's worth engaging the conversation. And, that's really what we're here. And, of course, the Wellness Committee as well. I'm going to skip through this part of the program. And I want to just highlight some resources for you. So if you are a person who retired from state government, HCA means the Healthcare Authority. So they are your expert people for eligibility, enrollment, switching, including all the forms, how making a change would affect any dependents on your coverage. That includes spouses as well as younger people, or how changing or leaving the group plan would affect other benefits you have, like dental. So you could just substitute here, Gary, you could just substitute OFM for HCA, and it works the same way. If you're part of a group, make sure to consult with your group, not just with Medicare. And then obviously Medicare, which we call the Centers for Medicare and Medicaid Services. You can find them at cms.gov or medicare.gov. You can call 1-800-Medicare. They're available 24 hours a day, 7 days a week. So if you have insomnia, you have someone to talk to. Our phone number is coming up in a minute. We live answer the phone in Tumwater Monday to Friday, 8 to 5, except for state holidays, and we'd be happy to hear from you. And there's no waiting. We answer the phone on time all the time, which I think is a nice compliment to the commissioner and his leadership. And then, of course, check in with your health plan, whether it's a group or an individual plan. They are the experts, and they are the authority about provider networks, prior authorizations, covered benefits, the formulary for prescription drugs, and then all the details. And then here is our information and our website. We would sincerely like to hear from you. We are always recruiting. Obviously, that's what I'm doing right this second. We're always recruiting for more volunteers. So if you're interested in helping out in whatever way you can, we would love to hear from you. Clearly, I'm angling for an invitation to come back again next year and try to make that machine make me hot chocolate, because this coffee was really good. So thank you very much for your hospitality. And Risa, we have time for questions? Yeah, Risa says sure, bring on the questions. How about questions? Oh, here comes the lights. Well, there went the mood.
Okay.
Are you going to do a walk around mic, Jim?
Yep, I
All right.
will, and Kathy's going to do the other one.
Okay. And you just say, do you want Tim or Mike? If you want
Tim.
me, then you want me. If you want the commissioner, you want the commissioner.
Tim, I think one of your early slides said something about expanding oral health. So can you address that specific to Medigap plans about oral health, vision? You know what they are. You know our issues.
I do. So that's a great question. That's one of the, if I think, was your name Molly? Nancy, excuse me. So I think that is going to be one of the most, so now having sort of conquered prescription drugs, dental care is going to be the next horizon for Medicare. And it's going to come down to simply like, how can we get enough providers to agree to come into Medicare to take the rate that Medicare wants to pay. And it's going to really also, I think in a good way, it's going to challenge our idea about, does it need to be a dentist, or could it be a hygienist, or could it be another person who has a different scope of practice? And
my understanding, Washington State Dental Association is not on board.
they are not. They are not. Nope. They're not. But let's wait and see, right? Because the leadership is changing. So if you came to my program last year, my last slide was saying one of the things that's the most hopeful for me is that in the past couple of years, we have more women entering medical colleges than men, right? So I think as we see more women dentists take on leadership roles, we're going to see a different attitude, and it's going to be more open, and we're going to see, a different way of thinking about this idea about Medicare. In the short term, Medigap plans, none include dental. So there is a market for private dental insurance. It's really weak. It's not great. So your best bet is really negotiating with your own provider.
So what about for vision and hearing aids? What do you see for the future of that?
So I think that's more possible, right? I think for people, right, and Marianne, I'm referring to John here, and folks who really want there to sort of arrest the slide towards Medicare Advantage plans and privatization, I think Medigap plans have to kind of level up to continue to be a meaningful alternative. And so, in my slide that I went through super fast, in 1980 is when, with the support of the National Association of Insurance Commissioners, the Congress standardized the Medicare supplement plans. And since then, they've tweaked them a couple of times. So I think that relief would come from support from people like the commissioner and the National Association of Insurance Commissioners to say, let's have standard, one of the 10 standard plans includes some kind of dental benefit. So I think that's possible. Is that possible, Commissioner? He says, whatever you say. He
All
didn't
right,
really
here
say
we
it. He never really says that.
Here we have another one.
Yes, please.
Do you know whether I, a Kaiser client, can get back on the traditional Medicare? I do not want to privatize through Medicare Advantage.
Sure. So the short answer, let me repeat the question. The question was, if I have Kaiser, which is a Medicare Advantage plan, can I switch back to original Medicare? And the answer is almost certainly yes. It would. What I would want to ask you, if I was a Sheba volunteer, is, do you have Kaiser from a group or did you buy it as an individual? So if it's like through the state that you have Kaiser, then you just switch to another plan that HCA offers. Or if it's like Gary, if it's from the Fed, you switch to, but you want to stay inside your group. But yes, and open enrollment time is the time to do that. And we'd be happy to help you navigate through that. But yes, you can do that. Who's gonna, this is like ping pong. We have somebody in the middle. I'm curious to see which moderator is gonna take the microphone.
I'll get them.
Okay, here comes Jim.
Well, let's go with Kathy.
All right, Kathy, I'm with you.
Hi.
Hi.
I'm puzzled about United Healthcare being a Medicare Advantage plan because we have United Healthcare and we're really happy with it, but we don't have any of the features that you mentioned that a Medicare Advantage plan has, like dental care or hearing or eye care or any of those things. But I know I did notice on our healthcare card that it said Med Ed. And I always meant to call and ask, but as long as everything works, you just let it pass. So, can you, is there a Medicare Advantage plan by itself and United Healthcare by itself as a Medigap, or are the two always combined with United Healthcare?
Yep. Did people hear that question? So this is a great question, and the answer is no. I mean, there are United Healthcare plans that are not Medicare Advantage plans. So the most popular in Washington State Medicare Supplement plan is the one that's the insurance company is United Healthcare, but it says AARP, United Healthcare, right? And so that is a Medicare Supplement plan. That is original Medicare, not Medicare Advantage. So remember my kind of flippant remark about if you said I had Medicare, that's like saying I had breakfast. So that to me is like if you said I have a Chevrolet. Well, let's keep talking, right? So if you say I have United Healthcare, there's more to the story. So United Healthcare is on both sides of original Medicare and Medicare Advantage. Is that helping?
Well, how do I know exactly if I'm paying more to have the Medicare Advantage? Not being aware that it advantage, I guess that enrollment type, I better ask my interlocutor about that.
Yes.
Okay.
Yes, for
Thank
sure.
you.
There'd
Very
be-
good point to
Call
bring up.
call the 800 number on the back of your card
Yeah.
and ask them, or ask one of the Sheba volunteers to help you. But yes,
And Shiva can be reached through that 562?
yes.
Okay,
Uh-huh,
thank you.
uh-huh. Yep, exactly. So if you call that 562-6900 number, they're going to say, where are you calling from? And you're going to say King County. And they'll say, okay, we'll have one of our volunteers call you back. And then we'll call you back and then we'll say, do you want to meet on the phone? Would you like to meet on Zoom? Would you like to have a personal appointment? And then we would tell you, these are the places in King County that we're seeing clients, and senior center, library. You don't like that. We could certainly come here and meet with you.
All right,
Yeah.
we have another question.
Oh, thank you for waiting.
Yes, I have a two-part. Oh, can I be heard?
Yes.
Okay, I have a two-part question. I'm assuming that a Medicare Advantaged program, you have to choose physicians within that network.
Yes.
And the second part is you say it's privatized. So then how is it financed as differently than Medicare?
Oh, such a good question. Those are both good questions. We should have a prize. Sarah, next time we have a program together, we need a prize for people that have like really good questions, like Snickers bar or one of those little betta fishes in a bowl, you know, like you get at the fair, something like that. Jim, next year, let's talk about, I mean, if you invite me back again, let's talk about prizes for really good questions.
Okay.
So financing for Medicare Advantage, what essentially happens is, and this goes back to the history of the Medicare program, still is true today, right? So what Medicare does is they say, we're going to imagine what we would spend in the original Medicare program, and we'll offer you, say, 90% of that to the private insurance company. And if you can make a profit on that by negotiating with the providers and by putting in managed care protocols, you can keep the rest as a profit. And so essentially, they're being offered most of what the Medicare agency would spend this way to do it a different way. Yes. Now, my boss is here, so I have to be a little careful. I will. And Risa's recording. But the question was, so then should I assume that how they're making money is that they're asking the doctors to take less? And the answer is yes. Right? And so essentially, and this is going to be a little bit crass, okay? But the bargain is like, if I'm the insurance company, I'm going to come to Seth and I'm going to say, hey, Seth, if you will take a lower rate in my group than you might get over here, I will help drive business to you. I will tell people, if you join my company, you have to see Seth, right? So in Seth's mind, it's like, gosh, I could maybe make up on volume what I'm losing on the margin, and I'm going to go with Tim's company, right? Because if he says no, if he's a little reluctant, then I might say, gosh, Seth, you know what? I'm going to give you 24 hours to think about it because I'm making the same offer to Jim, and I'm only picking one of you all.
The
Right?
other part of that, let's be a cynic.
Let's, you and me both?
Yeah.
Okay.
The cynic says the Medicare Advantage program will limit your care. They will place some limits on your care. If you want a knee replacement, first of all, you have to go through physical therapy and then to be determined that you need a knee replacement.
Well, I wouldn't say that's cynical exactly, but I think that's real, right? That's part of the bargain, and I'm gonna be like on both sides of this question, right? So clearly that is part of how you make a margin, right? Did I know your name? Will you say your name? Charlotte. So clearly that's part of how I'm going to make a margin, right? Is because I'm going to say, you know, you guys over here in original Medicare, it's like the Wild West, right? I mean, we have people who just say, my knee hurts, I'm going to go to the Virginia Mason Clinic and see an orthopedist, and probably if I just went to my general practitioner and got Tylenol, I'd be fine. But because it's free range, why don't I just do that? And so the company is saying, why don't we try Tylenol first? And if that doesn't work, then we'll talk about an orthopedist, right? So some of that is cynical and some of that is real, right? And this is a little bit of a delicate conversation. And the commissioner is an optometrist by training, right? So he is a clinician, so I have to be a little careful here. But to be really candid, right? This is like an adult audience. We can have like an adult conversation. In the history of the program, in the history of the Medicare program, there are these huge variations in provider practice that are not related to quality, right? So again, if you go like I know it's hard to think this far back, but way back in 1965, if you just did a survey around the country and you said, as a woman of a certain age, what's the likelihood that you're going to have a cesarean section when you deliver compared to a natural delivery? Or what's the chances that you're going to have a hysterectomy? And the rates are off the chart. And it's not necessarily related to you being better off, right? And so some of this is legitimate, and some of this is a little bit like cynical, right?
And who makes the decision, the doctors or the bean counters?
I think I think I'm a bean counter. Yeah. I think that's my job. No, both, right? I mean, there are some protections in place, right? But it is a bureaucracy, right?
Okay.
For sure, no question.
We had a question over here, Kathy.
Sarah, you're not allowed to do a program like this when you're in front of the room. Only I'm allowed to do this.
Thank you. So I'm a consumer, not a provider.
Right.
How do I make a choice between Medigap and Advantage?
I brought this giant chart for you. I made this last night. I brought this, and tell me your name again.
Marianne.
Marianne, I made this giant chart for you, Marianne, last night. They're at the back of the room. I hope I brought enough. If I didn't bring enough, I can make some more. This is meant to help you navigate how to do that. And the first part of it is be calm. First, just take a minute, because this is not for faint-hearted people. I mean, this is hard work. As my mom said, it shouldn't be hard work. She's right, but it's hard work. So what I'm gonna my whole colorful chart, and I want your feedback if you like this chart or not. It is three things. So the first thing is get some help. Get your posse together, and don't try to do this by yourself, right? Because it's effortful and it's confusing. And so find some emotional support, some practical support. That's the first thing. The second thing is make sure, and I know this is very difficult, but make sure you really know what you care about the most, because it gets really hard when you're kind of in the middle of it if you're not sure if you care more about seeing the same doctor or if you care more about saving $20. And what if it was $30 compared to $20? Because that's what it's going to come down to, is those kind of sort of micro negotiations, right? And then the third thing is get some expert help. Use the Medicare website, use the Sheba volunteers, talk to your providers. So get your friends, be clear about your own kind of values and preferences, and then use the tools and get some experts. But it's not easy. It's the opposite of easy. It's like really hard. It's painful. Sorry.
All right.
But we're here for you.
We have a question over here, and then we'll go to the center. Here first.
Oh, sorry.
In your presentation, you talked about the privatization of Medicare, and the Advantage plans is one, but there's another one you mentioned also, I forget the name, that your hospitals or doctors might join, and then you're given a choice, do you want to be part of it or not part of it?
Yep.
My concern is that suppose, I don't want an Advantage plan, I want to be traditional Medicare, but now my doctors in a hospital are going to this other option.
Yes.
And I can opt out, but if I opt out, is there anybody else left to treat me under traditional Medicare?
Did everybody hear Ann's question? Okay, I'm going to repeat the question. And so the concern, so that's really real, Ann. So the concern is I might not really want to be endorsing this solution by electing to be over on this side of the world, but what if that's the only way I can still keep seeing my doctor? Because that's what's happening, right? You're getting notices from your doctor that say, if you want to continue to see me, you have to sign up for fill in the blank name of company, right? So if we're at we went through this last year when we were here, right? Like Polyclinic or Everett Clinic. Like if you want to keep seeing a doctor here, you have to sign up for, or these are the plans we take. So that's really real. I mean, that's really real. And the second thing Ann said was also a different challenge of privatization. And the commissioner and I talked about this last year. In the beginning of time, until really a couple decades ago, most doctors worked in private practices. And then we started to see group practice, and now we have multi-specialty clinics, and now hospitals are buying doctors' practices, and private equity firms are buying doctors' practices, right? Because it's a lucrative investment for them, and we have a bunch of, and I'm saying doctors, but I mean, again, no offense, right, to other clinicians who are saying, the only way I can cash out this, long-term investment I made, no one wants my practice, is to sell out to a hospital or sell out to a managed care plan or sell out to a private equity, right? So it makes sense, right? I mean, they feel like they should be rewarded for all the effort and all the education and all the training and all the, right? But it is definitely, Ann, leading us into a treacherous place. I mean, I think the next decade is going to be really difficult, right? And the Biden administration has asked the FTC to look into these kinds of arrangements where we've got what they would call like vertical integration, right? Where hospitals are buying practices to increase their leverage to negotiate with the managed care plans. So, it's gotten really perilous, honestly. We're in a really challenging time. Again, apologies. You have way more questions than last year. This is fun.
I find this rather curious. I'm starting to think of the two opposites as being like the business-owned and the union workers. So I'll let other people decide which side is which. But it sort of seems to me that whenever we have a privatization, whether it be a business or an organization, versus a government role, meaning the two decision makers, you're always going to have the fluidity in favor of the privatized, which means that they have the motivation, they have the ability, the way that they are set up, to make quick decisions, so that they have an opportunity to go where the opportunities are, and they're driven by profit. And so that really, to me, is kind of how I compare things. Tell me if I'm in error.
I'm not sure everybody heard that, but I'm going to try to paraphrase. Tell me your name. Cassandra. So Cassandra's observation is that it seems like what's happening in this space, right, the original Medicare program or traditional Medicare, fee-for-service Medicare, is that who is the principal decision maker is the government. And the government has its own way of doing business, and it can be slow, fair. And then on this side of the world, the principal decision makers are private companies, which may move faster, but there may be other reasons why we should have some concerns about this, including their motivations, right, which are a lot maybe about making money, not necessarily what's in our best interest. Is that fair? And you're asking me to like endorse that view or validate that view. Okay. I do love to argue. So what I would say is that the tension that we have here is how much authority or how much regulation or how effective will that regulation be of Medicare applying itself to these private companies. And so, you heard the commissioner in his opening remarks talk about that what sort of happened for a while there was, and just picking one example, right, was Medicare Advantage Plan marketing was a runaway train. I mean, they were taking license, and it was confusing, it was misleading, it was super disruptive. And what I would say, and I think what the commissioner would say, is that was ineffective regulation. It didn't have to happen. We could have protected you all better if this relationship was stronger. So I guess I'm not arguing, right, but friendly argument, Cassandra. I think this can still, we can get kind of the best of both worlds. We can have a more open, deliberative process that you associate with government, and we can still kind of innovate and be nimble, but it depends upon this being really effective regulation, because there's a real possibility for this just to run amok.
All right, 2 more questions, and then our time is out.
Can you hear me? What is the possibility that Advantage Care plans are going to drive out Medigap plans and have them disappear?
Okay. So the question is, what's the possibility that these Medicare Advantage plans, if I could find the slide, that they're going to drive out Medigap plans and that they will disappear? If I don't find this quickly, I'll give it up. So essentially right now, if the market is about 1 in 5 people have a Medigap plan, what is the possibility that these MA plans are just going to crowd them out? And I think, to the question about dental coverage, I think that's a real possibility, right? What you have now is a concentration, if you will, in Medigap plans of affluent, white, city center people and people who live in rural areas where MA plans haven't had a foothold yet, right? So who prizes these plans are the people who like the freedom of choice. They want to go see whoever they want, right, for their knee replacement whenever they want, and for it to get taken care of. And they're not concerned about all the extra benefits of MA plans. They've made an investment decision. They don't want the insurance to pay for that. If they need eyeglasses, they'll go get them. If they need hearing aids, they'll go get them, right? But that pressure is real. It's increasing because MA plans are moving into more rural areas, and these plans are becoming less competitive in terms of pricing. So what you see on the other side, including in Medicaid and in some imaginary segment of the MA plans, is you have a concentration of younger, disabled, non-white people who live outside city centers. And so I think it's a real challenge for these companies. And to the question about United Healthcare, they have to make an investment decision whether they want to stay here or they're going to just move into this market altogether. I can tell you, as I said, the commissioner and I started working together 20 years ago, and we publish a list of all of the Medigap plans in Washington State, and it's not half what it was 20 years ago. And probably I could say 3 or 4 companies have 90% of the entire market for Medigap plans. So I think it's a legitimate concern.
All right. One more question. Over there.
And I'm happy to stay after and take questions, although I have a funny joke, but the commissioner and I rode together, so I can't stay all night.
Okay. I hope this isn't too specific a question, but I wondered if you would comment on the way Kaiser is working as opposed to other Medicare Advantages, because Kaiser, as it grew out of group health, as group health had to collapse itself and turn into Kaiser, was much more oriented toward what was, or at least my sense was, toward sort of a liberal interpretation of things.
Sure. I'm happy to. That's a good question. So I'm going to repeat the question because this came up you and I were talking about this, right? So what's the future for Kaiser? And especially like for those of us who came up with group health, the commissioner used to work at group health. That's where he had his optometry practice. And then, right, Kaiser kind of absorbed group health, and now here's Kaiser. And I think, and what you want to suggest and other people want to suggest is that Kaiser was a different kind of MA plan, right? They were more idealistic. They did have that orientation towards, it wasn't about making money, it was about taking care of people. It was a co-op, right?
You were talking about group health.
And now Kaiser, right? I mean, I think people still associate those positive attributes to Kaiser. I mean, so I would say, Jim, no one feels about Aetna, United Healthcare, Humana the way they feel about Kaiser. They have a different perception of it, right? They attribute a different kind of motivation and ethic to it. So the question is that going to continue to be viable? And I think it's an interesting question. You know, what you're seeing across the country now is that Kaiser is having huge rate increases, because the company is under-reserved. You know, they've got to figure out how to continue to attract enough investment income to stay competitive. So, you know, I think, to the same sort of horizon about Medicare supplement plans, you know, in 10 years, Kaiser is either going to be big like that or it's going to be gone. But they're in that same, in my judgment, and tell me if you have a different point of view, Commissioner, but they're in that same kind of space where the world changed and they're challenged to keep up. Can I say that? He says yes.
All right. Thank you very much for coming, Commissioner and Tim. And thank you all. Tim will remain for a few minutes and you can come and ask him questions.